going for an introduction now. Sir, it's over to you.
Sir, you are muted. Sorry.
Hello, friends. Hi. Good. I am fortunate to have another session with you. Good evening and good afternoon or good late evening for some. But as Sripriya said, we are going to talk about a very relevant session. Relevant in the sense that many of the things that we have talked about so far are things like directly related to diseases, symptoms, people. Here we are kind of going to talk about something more related to medicines and things like that. Now, there is a catch there. You did your basic medical or dental education. Many of you did a postgraduate education. And you were all learning about things connected with medical practice. You never had to go and see whether it is necessary for you to see if the pharmacy was sending the indent on time, whether the medicines are arriving. And most of you, there may be exceptions, did not have the responsibility to go and see whether the next order has been placed, whether there is an interruption in supply. Most of you did not have to do those things. I know Sairu had to do those things often, but most of you did not. What is it that we want to do? When we do learn palliative care, what's our objective? Our objective is clearly to improve the quality of life. Now, the commonest symptom, of course, is pain in most chronic diseases, particularly cancer, so many neurological diseases, and in peripheral vascular disease, and so on. And all your skills in communication will be pointless unless you are able to clear the mind of the preoccupation with the pain, because pain is all-consuming. It occupies every moment of the person's life. And unfortunately for us, in 2/3 of cancer and in many other situations, 2/3 of cancer pains, it cannot be relieved without step 3 opioids. The vast majority of you are from India. What are the opioids available to us? Type it up, chat box. What are the step 3 opioids of step 3 available to us? Not injections, other formulations, excluding injections. Morphine, of course. Anything else in step 3? Buprenorphine, Priya, 1 second. Priya, buprenorphine, I would not call step 3. It's a bit difficult to classify. I'll explain why I say that, Priya. But between Vidyasaharan and Amrita, you have already talked about the other medicines. In our country, except for injections, we have only 3 medicines, the step 3. Morphine, oral methadone, and transdermal fentanyl. That's all. Transmucosal through buccal mucosa was brought in by some company. I don't think they are selling it anymore. So for those 2/3 of people with cancer pain and for many other patients in pain, we will have to play around with these 3 medicines. I guess very few of this group here would have access to anything other than oral morphine. Very few of you may have methadone. I'm not going to talk about how methadone is to be used, but I can tell you, sorry. Apologies for the explosion. But I can tell you that for roughly 1/4 of your patients with cancer pain whom you start on morphine, the quality of pain relief will not be optimal. Unfortunately, 3 out of 4 people will have excellent pain relief without unpleasant side effects, 2 unpleasant side effects, but 1/4 will not. You know them, you see them. And you will need these other medicines. So these are the 3 medicines that we will talk about their availability. Priya, why I said buprenorphine is not a step 3 medicine is, I would request you all to think, what is so special about step 3 medicines? There are other opioids. You have tramadol, you have codeine. What distinguishes step 3 opioids from step 2 opioids?
Ceiling effect?
Priya, absolutely. Thank you. Ceiling effect. With morphine, methadone, or fentanyl, depending on the degree of pain, if the pain is opioid responsive, you can go on increasing the dose. Hey, what is the highest dose that you have used of morphine?
I had a patient of ruptured aortic aneurysm for whom I had used 80 milligram. This is
Injectable?
yes.
Okay. Yeah, I mean, that person needed it, Priya. Absolutely. The only catch is if all of a sudden the surgeon opens up and it's repaired and he closes up, you may find that the person is respiratory depression when the pain is gone. But of course, that we can handle. That person needed it. Amrita, what is the highest dose you have used? Amrita, you are muted, Amrita.
Can
You
you hear
can.
me? Can you hear me?
I barely shout.
Okay. So actually, I think we have gone up to 200, but that was before the introduction of methadone.
Okay. 200 milligram 4 hourly orally, right?
No, sir. Total dose 200.
In a day.
24 hours.
In a day, you mean? Oh, okay, okay.
Yes,
Okay,
sir. Yes, sir.
Dr. Ashok Matthew, how about you?
Yes, sir.
How much?
I have gone up to 120 milligrams per day.
Okay,
And
120. That's just 20 milligrams 4 hourly.
yeah,
Thank you, Ashok. Sairu, what's your highest?
Sir, no, sir. I mean, like I have only seen. I have not personally used it.
Mhm.
I have only seen it being used. And
I'm asking about morphine and large doses. I had a teenager with fibrosarcoma once. I don't know if it was bleeding inside, but in her last few days, it was growing visibly. You see her today, you see her next morning on rounds, and it is almost double the size. And we had to keep on increasing the dose till she was on 250 milligrams 4 hourly. Okay. No respiratory depression, no drowsiness. At that point, it became tolerable. You can do your maths, 250 into 6. Okay. 1,500. And this is not everybody. So Amrita said she used to use high doses before we got methadone, precisely. There you go. Sunil Kumar has used 450 milligrams 4 hourly. So these are the exceptional patients. So Priya, rather clearly, there is no ceiling effect. This ceiling on top of your head. You increase the dose, you hit the ceiling. Now, buprenorphine does not have a ceiling effect. You increase the dose up to a point, thereafter, increasing the dose is not possible. It may not be a pharmacological ceiling effect. That's what the industry representatives tell you. But there is a ceiling effect caused by adverse effects, and you cannot increase the dose beyond a certain limit, which is why we do not use buprenorphine in step 3. It is, if you ask me, I'll place it somewhere between step 2 and step 3. More potent than other step 2 medicines, but that's all. So, and legally also, buprenorphine is not covered under the same schedule. In the law, buprenorphine doesn't come under the same schedule as morphine, fentanyl, or methadone. Okay, so we will need these 3 medicines. And today we are going to talk about how to make them accessible, because doctors, if you do not take the trouble, for the majority of you, nobody will. This is not something that many pharmacies are used to. And they may deal, I mean, you may teach them and they may deal with it like any other medicine. And then you find that there is an interruption in supply. And if you do not know how to use it properly and document it properly, you are running a risk. Oral morphine by itself is not likely to cause addiction in cancer pain. That's all we say. We cannot say that addiction's risk is 0. And if there is somebody who is a known patient of addiction, that person may want large quantities and it may get diverted. So you will have to make sure that your morphine is kept safely and documented safely, because if there is an unusual trend, you should be able to assess them. So this is the purpose of our discussion today, to make you familiar with the opioid regulations, and to make Dr. Sujarita and Dr. Kamal Shigli and everybody else, Nikhil, we are going to learn a little bit about this and take the responsibility to make sure that there is uninterrupted supply of step 3 opioids. Parul says, one of our colleagues working in the state government institute is facing issue in managing pain at home care since oral morphine availability is not there. Only injectable morphine is there. No setup for home visit and managing injectable opioids. So Parul, towards the end of the session, please remember to come back to this during the discussion time. We will see how that kind of problem needs to be sorted out.
Okay.
Sri Priya, will you please help me and switch the slide on?
Sure, sir.
Next, please, Sri. So I'm skipping this because you have already somebody said, but I'm sure there are many people in this group who do not have access. Sri, go on to the next. Let us unanimously accept this responsibility. in the interest of patients that we serve, to take both these steps. Our duty is to make opioids available for those in pain, but also to use it in such a way that abuse is prevented. We have to accept this dual responsibility. This is something laid down in 1960 or single convention onwards. Okay. Sri. So to people in pain, how many people with serious pain in our country? Take a guess. Cancer alone, maybe something like 1.5 million. 15 lakhs. Not to mention other conditions. So to them, we owe it to them to make you understand opioids. Other doctors may not. So that's why we accept the responsibility to assess the barriers. Why does Parul's friends have a lack of access? Parul, this is an exercise that we will take up with your friends. Instead of just saying we don't have it, we'll find out why they don't have it and take remedial measures and make proper documentation and keep advocating for pain relief. That means for balanced access. Sri, next one, please. Fortunately, many of the barriers to opioid access have been removed with this one step in 2014. Remember, we had to go through a lot of work over 19 years to change the law. In our country, a law is not implemented automatically. Even now, many states have not implemented them. And we have in Parliament a facilitation team who is working with palliative care activists everywhere, anywhere in the country to approach the drug controllers. This last year, I think we did 5 opioid availability workshops in different states, where we sat together virtually with in one place with the health secretary, in another place with the additional secretary health, with the drugs controllers, and sometimes with other officials and doctors. Sat together and discuss how this is to be done. So we will have to understand a little bit about this change in law. Next, please. So Parul, you and your friends need to understand that these are the barriers that have been overcome. You said your friend's hospital has injectable morphine for use in the hospital. The old rule, the law, 2000 till 2014, every institution needed all these licenses: possession license, import permit, export permit, transport permit. Oh, transport permit was only in some states. Now, to get these licenses, multiple agencies were involved. In most states, it involved the drugs controller. Maharashtra was an exception. But in other states, you had to go through the excise, and very often the director of health service, etc., and then the drug controller also. And short validity licenses. I remember that Bihar had a very short time. So what happens is, this is how we got the morphine ourselves in Calicut in the 1990s. First, we had to get a possession license, get an import permit. That also I had to do. This came from the excise after permission from the drugs controller. This also came from the excise in the capital. And then I had to send this to the manufacturer. At that time, it had to be either Gujarat or Maharashtra. I sent these licenses to the manufacturer, and they then had to apply to their drugs controller to get an export permit. And once it happened, that by the time there was a delay to get the export permit, And then they sent the medicine across by registered post. By the day it came to us, the import permit validity had expired. And we could open the parcel only in the presence of the drugs inspector. And validity was gone. We could not open it. We had to send the huge parcel back to Ahmedabad and apply for a fresh permit. And people were left in pain. People who had been literally taken out of drowning in pain and breathing now plunged back into that deep sea of pain. No, no longer. In those days, every state had its own rules. No longer. All states now have the same rules. The power to make rules has been taken away from the state to the central government. Only for what they call essential narcotic drugs. Those 6 drugs have been named as ENDs or essential narcotic drugs. For our purpose, only 3 are valid. What you mentioned earlier, morphine, methadone, and fentanyl. So for them, now we have uniform rules. And according to this, you don't have to apply for the licenses, but you apply to the state drugs controller for approval as a recognized medical institution. In some states, pharmacies are given a license to sell. Most states do not. We are not talking about it. That's applicable to 1 or 2 cities in India, or 3 or 4 cities in India, nowhere else. That's not a good route. The good route is Dr. Vidya Saharan. You have, Dr. Vidya, do you have access to morphine?
Yes, sir.
Methadone?
Yes, sir.
Okay. So you have which state are you in, Dr. Vidya?
Sir, I'm in Chennai only, sir.
And
Can
you have, your Life Care Foundation has approval as a recognized medical institution, which has been given by the state drugs controller, right?
Yes, sir.
So no more licenses. The hospital authority just sends the order, makes the payment, the parcel comes. So that's how simple it has been made, provided the law has been implemented, like in Tamil Nadu and several states. Sri, next slide, please. Now, one word, a term I would like you to understand. There's a difference between law and rules. Law is something that is created by a legislative body. In this case, it was the 2014 law was created by the Indian Parliament. For some other matters, state can legislate, but for this, it had to be the government of India. Parliament passed it. That's the act or law. For implementation of the law, rules are created by an executive order. So suppose it's a law regarding healthcare, the Parliament may enact it, but the Department of Health will create the rules. So similarly, for implementation of this law, because it's operated by Department of Revenue, the Department of Revenue create the rules that took 1 year. So this came in 2015. In that rule, they named, as I said earlier, morphine, fentanyl, and methadone as ENDs or essential narcotic drugs. And like Life Care Foundation in Chennai, any institution can become an RMI by applying to whom? Only one agency, the state drug controller, no one else. Applies to state drug controller, he or she gives you a permission to be an approval as RMI, and you place the order. This approval is to stock and dispense opioids. If about any of these points, Dr. Yadav, I will come back to your question a bit later. Kavin Kumar Saravanan, it doesn't matter if it is in the center or periphery. A private health clinic can get RMI status. Any healthcare institution, including a home care program, it's clearly specified in the rule. You don't even have to have a hospital or a clinic, but you have to have a room for safekeeping. So if your office is running only a home care program, still according to the rules, you can get the status of an RMI. So we'll leave Parul's question and Yadav's question hanging in the air for the time being. Any other question? No, they are important questions, but I'm coming to that bit later. Okay, shall I go on then? Sri? To become an RMI, to continue to answer that one question, you need one doctor to be in charge of the RMI. The doctor should have had training in pain management. Okay. The rules do not specify what that training is. So who will decide? As it happens now, it's up to the drugs controller to decide. No other official body has decided on any particular training as necessary for this purpose. Now, so what happens? In Kerala, the previous decision by the drugs controller, we had a standard operating procedure that a doctor had to have at least 10 days of practical hands-on training. That was the rule. But during the COVID days in 2020, we approached the drugs controller for a relaxation in this because it was simply impossible to train everybody. And he gave us an order which approves virtual training as adequate. Now, most states, when any of you can have this, because you may take it to persuade your own state drug controller if there is a question, but most drugs controller accept any certificate of training in pain management or palliative care as adequate. Of course, it's essential to know how to use it, otherwise the patient is in trouble and you are in trouble. Sri? Yadav asked, can a government medical college, does a medical college need to apply to become an RMI? Yadav, the answer, question is simple. The answer has a qualification. According to the rules, all government hospitals, not only medical college, tertiary, secondary, primary, home visit, anything, all government hospitals are deemed to be RMIs. You do not have to apply. No prior approval is necessary. But they also must ensure all documentation. Annual consumption data will have to be provided to the drugs controller of the state. So the rules are placing a lot of trust on government hospitals. But so you say I am a deemed RMI. Yadav says I am a deemed RMI, and straight away the hospital applies places an order with the manufacturer. If there is a manufacturer, in the state, you may be able to talk to them. If not, it will be in another state. So what happens? They will say, oh, sorry, sir, we need your RMI certificate. And the reason is, in Kerala, the drug controller says he does not want anybody to have morphine without a certificate of RMI, even in the government sector, because he says he cannot possibly keep track who will order where. So the manufacturers, there are very few, they know that the drugs controller asked for this. So secondly, Yadav, there is another problem. If the certificate is not there, not only you may find it difficult to get the drugs, but also in future, somebody may use it without proper documentation. The advantage of having the RMI status also is that you know, okay, the drugs inspector will come and check. Maybe once in 3 or 4 years, but it happens. And we have to keep the documentation properly. If it becomes very irregular, the whole palliative care movement will suffer. If there is one rumor going out from one of your hospitals anywhere in the country, Yamini, James, Swati, in your hospitals, it goes out. All of a sudden, 1,000 tablets of morphine have disappeared. It will get into the papers. All the work we have done over 35 years is sunk with one scandal. So we have to ensure responsibility. So Yadav, in Kerala, it is not according to the rules strictly, but the drugs controller insists on waiting an order. In other states, if you send in enough evidence to show that you are a government hospital, other manufacturers outside Kerala may give you the medicine. I hope that's clear. The situation is not very clear, but I hope the answer is clear. Sri? There will be many more questions and I'll answer them when necessary with some slides. But I wanted to show you how Amrita is keeping stock of the medicines. This is our register. The first few items in red are only about receipts. So on 11th of April 2019, our institution received from a manufacturer within Kerala called Lisi Hospital Pharmaceuticals, morphine in batch number this A344 with the date of manufacture being this and date of expiry this. She got 24,000 tablets and received on 19th. That is added to the stock here. It is there. Every single dispensation is entered with the patient date, patient's registration number, name, and quantity issued. The rules say you actually have to write down the address. We do, not in the register, but because we have the number, we have the case sheet with us, kept with us. So anytime we can get the details on the patient's register. So when the inspector comes and asks, show me the prescription, it is available in our case sheet. If you cannot keep that record, you will have to at least keep a duplicate of the prescription. One prescription goes out to the patient, you have to have a duplicate prescription in your files. The number of, this is of course, if it is 10 milligrams, this register is for 10 milligram. Amrita keeps another register for 20 milligrams, another for 50 milligrams, another for methadone syrup, another for transdermal fentanyl, 25 microgram patch, another for 12.5 milligram per hour patch, and so on. Of course, it's possible to keep it all in one register, but this is simpler actually to have one formulation, one register. I'm just telling you some practical things because the pharmacist may not be familiar with it in your hospital. So after every patient is dispensed morphine, the closing stock is entered here. So this is how we do it. Yes, Yadav, it is better to apply for RMI status. The drugs control, it is fairly fast. The rules say that the drug controller has to give you a response within 2 months, either the RMI certificate or a rejection. If he has to reject it, he has to show the reason why. We'll talk more about the application presently. But about the documentation, I hope this is clear. Sri, next one, please. So, for some of the other questions, if you go to this link, which I am sure Sri Priya will share with all of you, this will give all the relevant forms. So you actually have to fill up 2 forms, only 1 page, not complicated. One will have to be signed by the hospital administrator, director, superintendent, so whoever, the head of the institution. The other has to be signed by you, the doctor who has had training. In the institution, the doctor who has had training signs the other form. That asks for a few things to the head of the institution, like how many patients do you see in a year, etc. Very routine stuff, nothing difficult at all. Only one difficult part will be, how much did you use last year? So if you are a new applicant, you say, I'm a new applicant. That's all. How much do you need for the next year? How do you know? Yadav doesn't know whether he would have 20 patients or 2000 patients. So what we usually recommend is, for the first year, just apply for half a kg. In the first year, an institution is unlikely to use more than that. And if there is some leftover, what does it matter? We'll use it in the next year. But other forms are fairly simple and clear, no confusion there. But if still you have doubts, please open this link. This is a document that has been created by Dr. Nandini Vallat, who is the current head of Department of Palliative Medicine in St. John's Medical College, Bengaluru. Very clear document. And that will answer most of your questions. So, Dr. Yadav now fills up the 2 forms. But then Yadav has a doubt. Hey, what should I fill in this column? So what does Yadav do? Yadav connects with us. We have been doing it for such a long time. We have gone through all the problems and all the possible mistakes. We have learned from them. We are here to help, even to fill up the forms. Absolutely no problem. We love doing this because 5 minutes spent on it means a few more people get paid. So that goes in. As I said, sometimes the drugs controller may send the drug inspector to you, Yadav. He will want to see where you keep the morphine. It will have to be in a steel cupboard. If you show him a cupboard with a glass case, he will say no. Somebody can break open the glass door. It has to be secure. There is also, this is not in the rule, there is also the time-honored custom of having a double locking system. You know the kind of thing? You have it, possibly some of you have it in your homes, where you keep the gold ornaments and your jewelry inside a small cupboard, small shelf within the cupboard. So you have to open the cupboard and then use another key to open this, which of course all the burglars know, and they will come directly to that shelf. But this is the idea. The drug inspector may ask for it. For us, what we do is double locking system. Yes, one is for the cupboard, the other is for the room. We keep both locked. So within 2 months, generally, the drug controller sends you the RMI certificate. Usually, this is the only thing that they do. They will want to see the register. Where is your register? You may show him a blank register where you are going to keep it. Yes, Dr. Yadav, the pharmacist has the custody. But you are in charge. Not only the pharmacist. Ordinarily, for other medicines, the pharmacist is in charge, but the superintendent is also in charge, right? Similarly, for opioids, we also, in our institution, the pharmacist keeps the medicines, dispenses them, gives them to the ward in substocks, gives out amounts for doctors and nurses to take for home visits, keeps them all back when it comes back, and pharmacist does that. But Amrita goes and checks periodically. And somebody countersigns. Amrita or I or Sunil will countersign, because we are the 3 doctors authorized in our unit to be in charge of the RMI. In some small institutions, okay, you are doing a rural palliative care center. It is just you and a nurse. That's fine. You don't need a pharmacist necessarily. Long back in the 1990s, the Drug Control General of India gave an order saying that palliative care centers are exempted from the need for a pharmacist. I would very much like to have a pharmacist, but if your institution is small and you don't have it, that's also okay. Any new question? Sri, I'll stop there for the time being, and I'll start with the questions that are already pending. So, Parul, we are going to work with your friends, okay, in the State Government Institute. Which state, Parul?
Sir, Agra Medical College.
Oh, UP, okay. So, Sri Priya, will you make a note to alert our facilitation team to connect with Parul and help this doctor?
Sir, actually, the institute have started the process of getting oral morphine, but still they have not yet received.
Parul, that's where we need to go in.
Yeah.
They may have gone in the same process that they did a long back, applying to the excise, etc. We shouldn't accept it. If they say we can get it, okay, it may take a little bit of time, but we'll go through excise. We have to be insistent. Make sure that the symbol system that's operative now is used. We'll work with the government and make it happen. Because if we don't, there will be interruptions in supply.
Yeah.
So, Yadav's question is taken. Kavin Kumar's question taken. Will a doctor with PG degree in diploma in anesthesia be eligible to represent RMI? And Dr. Ramesh, if you are able to give a certificate that's convincing to the drugs controller that your degree or diploma training included training in pain management, with enough training and use of essential narcotic drugs, he can. But ordinarily, for the majority of institutions, our training did not include use of oral morphine. I passed anesthesia, and in the same institution, it took another 30 years after my time for them to include that in palliative care training. So suppose it is one of those institutions who are doing MD in palliative medicine in the institution, there the PGs may have learned it. And a certificate from your head of department saying that this MD course in our institution included training in pain management, that may be enough. But then the drugs controller will have that option. Oh, no, I need a separate certificate. If those are things happen, that's the time when we work with them. We never go and fight with them. But we are insistent and make sure that they understand it. Dr. Yadav, Dr. Yadav asked, suppose the doctor in charge gets transferred to another college, another institution, what precautions we can do to ensure the continuity of morphine supply till another takes charge? Common scenario. This is the problem if you do not have a backup. Though I was originally the one doctor with who was in charge of the RMI, we made sure that Sunil and Amrita also were named as doctors in charge. Now, this backup is the best thing. Yeah, when this happens, the rules allow the institution to continue to keep it there for 2 more months, during which time a replacement will have to come and take charge. But if that replacement does not have training in pain management, the only thing that you can do, institution will have to do, is to write to the drugs controller and say, we can't use it. We want to give it to another RMI. And you have to identify the RMI to whom you will give it. And Amrita, at least a couple of times we have received consignments like that. So that's the process. But of course, you should have a backup, preferably. Or you will have to, those 2 months, somehow you will have to, within those 2 months, another will have to come. Yes, doctor. Nishad, as I said, in Kerala, the virtual training has been accepted as adequate for training, for RMI. And in most states, nobody objects. You are supposed to submit an application, substitute training with your application. You give your FCPM, and that's okay. But there is no guarantee that a drug controller may say it's inadequate. But then that kind of a decision can come any time from anyone, because unfortunately, the government has not decided on what is adequate training. There are a few problems with the current rules. So from 2017, we have been trying to revise the rules. And there's a new director of narcotics in charge in Department of Revenue. He has promised us that by the end of February, he will give attention to this. So we will try to resolve those issues. So there is a question from Khushbu, but before that, Parul, you have raised your hand. Would you like to ask your question?
Yes, sir. Sir, my actually concern is, in the meantime, we'll get the oral morphine. I'm talking about the my colleague of mine. How she can manage the patient at home care, because in the hospital she is using injectable morphine, but as soon as she has to send the patient back to the home, she has nothing more than a tramadol to give, and that creates a very helpless situation. sir.
I should not have muted myself during the explosions. At least those who are sleeping would have woken up. Hey, here we have a real question, relevant question from everyday practice. Sorry. Raju, have you ever sent morphine injection or given morphine injection in a patient's home? Raju, you are muted. No, you are not audible.
Sir, can you hear me, sir?
Yes, now I can. Yes.
Sir, we have never handed over a ampule to any patient anytime.
Okay.
But there were occasions when we given a refilled syringe, which is enough for just 24 hours.
Did you hear that?
Operation.
This is not specified in the law or rules. It doesn't talk about it.
Yes, sir.
But
I understand.
what we do is almost precisely the same as what Raju said. Indian Association of Palliative Care, thankfully from the initiative of Dr. Stanley McCadden of Baptist Hospital, has created a guideline, a position statement, saying that it is permissible for injections of morphine to be given in the home by the patient's family member. As Raju says, it will be foolish of us to hand over ampules to patients. We do the same thing. We don't do it often because we have oral morphine, and most of the time it's only rarely that somebody cannot. Of course, sometimes oral drug cannot be taken. Then we try to put them in inpatient facility. But if it has happened in the past that the patient says, no, I don't want to go to hospital. I'm not going to get to any hospital. That's the patient's wish. So only difference from what Raju did was what that we do is we fill that syringe with enough medicine for 12 doses to be given over 2 days. And the patient's family member has to bring the syringe back and take another syringe home. So there is no law covering this. This is a practice that palliative care pioneers have developed in India, and we continue to do it. But if it becomes a legal issue, how much time do I have, if I have any time left?
Yes, sir. You have time till 7:30. We have not taken up any case for today.
Okay, okay, thanks, Sri. So here is a case, of course. The patient in pain, not willing for admission or no facility for admission, unable to swallow, or for other reasons needing injectable. This is what we do. Is this legally permitted? My answer is there is no law against it. First. Second, in the absence of law, what courts go by would be a previous court judgment. In the absence of that also, courts generally go by position statements or guidelines given by professional organizations. So if it comes to that, I will show the code. This is what is advised. But I also want to tell you of another option. So, Parul, your friend must get the RMI status and should use oral morphine and send it home for patients. But if injection does become required, this is the process that I would recommend. There was something else that I wanted to say in that connection, but it has slipped my mind. Quantity of drug approved. Khushbu, can you clarify what you mean? Approved by the drugs controller, do you mean?
Yes, sir. Usually in our hospital, it's said that we can provide 10 tablets to one patient, and within a month or so, they get the morphine get out of stock. So they're like, we have limited quantity approved. So how it is decided and how much
Khushbu,
drug one RMI can get?
Khushbu, according to the new law and new rules, there's no ceiling for the quantity that you can buy and keep. Your problem, Khushbu, which state are you in?
Odisha.
Possibly. I don't know. Orissa has RMI status, doesn't it? Your hospital has RMI status?
Yes, sir.
So, with the new rules, there is no longer a quota system. You buy the quantity you need. There may be some hangover from the old days. The hospital may be insisting on it, or the drugs control may be insisting on it. And that's where we come in and clarify things to the hospital administration and clarify things. We will work with you to give the clarifications to the hospital or to the drugs controller and sort it out. This has to be sorted out because this is not only about Khushbu's patients. This is about patients in the whole state of Orissa. You should be able to procure as much of opioids as you need without this horrible thing that's happening.
Okay.
So Khushbu will let us address the problem and sort out, find out where the catch is.
Okay.
That's important. We have to find out where the catch is and then resolve it. But wait a minute. Sorry. Bolo? Khushbu, you said something else?
So I said thank you, sir.
Okay. Most welcome. In Kerala, as I said, even for government hospitals, the drug controller says, let us continue with the RMI status. That's okay. We are not going to fight that. Though it is not according to the law, it's okay. It's not a big problem. And the drug controller says, let us continue to have a quota system. And we accept, okay, let's have a quota system. He's generous with it. If the quota gets exhausted, we can ask for a supplementary quota, that's all. But so I'm just clarifying that only in Kerala, your annual statement of consumption also will include a form mentioning your requirement for the next year. If the drugs controller says you can have such and such a quota, that is not quite according to the rules, but even in that case, you can get an extra supplementary quota allotted. Priya, I'll come to your question presently, but before that, Dr. Ashok Matthew.
Yes, sir.
Hello.
Yes, sir.
Yes, your question.
Yeah, I had a patient from Andaman, a child who was having retinoblastoma, and she was seen in a hospital here, and pediatrician has prescribed. She had undergone treatment, but the patient was comfortable. There was no pain, nothing. But the pediatrician has prescribed morphine, 30 tablets, because the patient is going back to Andaman. And he has sent us to a prescription saying that we should add on another 30 days supply of or 30 tablets of morphine. Is it legally possible, or do we have anything to do against that?
You cannot dispense morphine with the prescription of a doctor who is not connected with you. If it is in your institution, it's okay. So what are the options? You can see the patient, register the patient in your institution. If you feel a prescription is to be given, you give it and give the medicine. Okay.
No, sir. The reason.
That will depend entirely on you, only after you have seen the patient.
Yes, sir. So, but then the reason what I am asking, the patient, when I saw, she was not having any pain. She was very comfortable. In that case.
If this patient is having malignancy, as it advances, pain may happen. And if you feel that it's a genuine situation, what I would do in you, I haven't faced this situation, Ashok. In your situation, what I would do is, if I feel, okay, this patient is going to Andamans, this thing is likely to grow, is going to cause pressure and cause pain. And I will just record only the truth, saying that though this person is not in pain, this condition is very likely to cause pain. And therefore, I would prescribe a morphine, oral morphine, in such and such doses to be taken when pain comes. And that's the documentation that I will make. But that's only if I am convinced that this is a genuine. I am taking the responsibility. Ashok, that doctor who wrote it will not take the responsibility. There are two things you have to consider. What you do has to be genuine and has to be safe for the patient and safe for you also. You don't want to get into trouble. But there's another aspect of it. There is nothing in law that prevents your giving a medicine to a patient whom you have seen in another state or even in another country. That is quite permissible. But you decide whether it is justifiable, and if it is justifiable, after seeing the patient, you take the responsibility and do it.
Thank you, sir.
Priya has asked a question and Parul has already answered. Priya, we are in this business primarily of improving quality of life. When I did the introduction to palliative care, one of the things I might have mentioned are the number of people who go into poverty because of healthcare expenditure. And Priya, do you know what's the difference in cost? Say, suppose you give somebody morphine and the equivalent dose of transdermal fentanyl, the difference is 150 times as much. Okay. That's how much. And a poor patient, okay, it's okay if the person is from Birla's family, but somebody like me may be able to afford it for a month. But somebody who is a manual laborer, your fentanyl will make sure that the children of the family go hungry within a week and they may lose the hope. So but that's only one aspect. The first answer is what Parul has said. It is not affordable to the majority of people in our country. But there's a second answer. Priya, fentanyl is not a good medicine to start pain management with. So, Priya, what is the strength of the transdermal patch available to you? Is it 25 microgram per kg per hour?
Yes, sir, this was just because this patient was not getting oral morphine. Until things were visible, I was thinking of a stopgap arrangement because
Okay,
I
okay.
need to give for a
Understood.
relative might be a little difficult.
Understood. So
Yes.
you have three things in the country: morphine, methadone, and fentanyl. Methadone and morphine are not available. Fentanyl is. But Parul, just give it a think. An interesting question. No, to Priya. Priya, these three medicines are in step 3. They are covered by the same law. Okay. No difference in the law, no difference in the rules. But so many places have fentanyl. They don't have morphine. Why? You have to ask yourself that question. That is part when you say, okay, I don't know. We are unknowingly becoming part of a cruel system which inflicts needless suffering on patients. Same law, but if a hospital wants fentanyl, the company people will come with all the forms. You only have to put up the signature. They will take it and bring you all the orders. How do they do it? You can take a guess. And we owe it to our patients not to be doing that. So I totally agree, Priya. If you don't have anything else and the patient can afford it, it may be a second option. But as I was about to say, why I say it is not a good drug for starting the treatment with is if you are using a 25 microgram per hour patch, which is what is usually available in most places, that's the equivalent of approximately, it's very variable, but 10 milligrams of morphine orally 4 hourly. That is 60 milligrams a day. If your patient's requirement is only half of that, and you are using this patch, what will be the outcome? After about 6 hours, the patient says, my God, excellent, my pain is gone. And the next day, the patient doesn't wake up. Very drowsy, breathing 6 times a minute, or patient is delirious or agitated. Or if the patient's requirement is 20 microgram per kg, then the pain relief will not be adequate and you will know it only the next day. So the ideal thing is for those, okay, we keep transdermal fentanyl. Amrita and Sunil, you must be using maybe that for 1 or 2 of your 5,000 odd patients, right? For those who can afford it, it is on the positive side. Generally, if you find the equipotent dose, side effects are less. Drowsiness is a bit less. The chance of vomiting is less. And you don't have to keep swallowing tablets. One patch, okay for 3 days. Take it out and apply another patch on the 3rd day. Bas, okay, come. So it has its place where affordable.
Sir, can I ask a question?
Yes.
For this home care, where Dr. Parul's case, where injection you mentioned, and the technique of sending it for a 1-day dose. So this will require the IV line to be in situ.
No, Dimple. The preferred route of administration is subcutaneous.
So this will be an insulin syringe?
I mean, no, ordinarily, no, Dimple, because we usually dilute the required dose in a syringe, 10 ml. Okay. In such a way, the dilution is such that 1 ml will be 1 dose or half an ml will be 1 dose. You are not going to talk milligrams to the patient's family. You are saying every 4 hours, push 1 ml in. Okay, so the dilution is such that you give that specific quantity, half an ml or 1 ml, every 4 hours. You dilute it that way. And you put up a butterfly needle and it stays there for a week. Maybe next week you can take it and put in another one in another site.
So can you explain the dilution ratio?
So how much do you need? Okay. Dimple, Sunil or Amrita, do you have a slide showing the calculation? If not, I'll just explain in a minute. But Dimple, if I ask you to wait to see if Sunil or Amrita can find a calculation slide.
Yes, sir. Sure.
I'll try to address Raju's question. Dr. Raju asks, do the present telemedicine guidelines in India permit repeat prescription narcotic analgesic drugs for patients who have been registered earlier after physical consultation? And the answer is no. Telemedicine guidelines clearly banned it for control medicines. So, but nothing prevents us from giving a repeat dose on the basis of a report from the family member. Somebody comes across, or even a volunteer comes over. We ask the questions to make sure that the situation is genuine and we give it to them. But not, just a repeat prescription, but telemedicine unfortunately has banned it. So what we do is, Raju, if a patient is in another city and if we have a doctor with training in pain management, we enter into an arrangement where we appoint him as an honorary physician. And then we have to take the responsibility to do it. A clinic with a single doctor, if it's a clinic, if the doctor is applying as an individual, then it's a very tiny quantity that a doctor can get. But if it's an established clinic with a registration, Shaji, which state are you in? What state? Sorry?
Good evening. I am from Kerala.
Okay,
Kollam.
Shaji, in
Yes.
Kerala, a clinic is typically, or a healthcare institution is typically registered legally with a local self-government institution. If you are in the city, it's with a corporation. If you are on the road, some people may operate without a registration. But for this, some kind of proof that you are genuine will be necessary. So if you are registered as a clinic with your panchayat or municipality or corporation, that will make you an authorized clinic. And there is, whether you are in a village, single doctor, or a medical college or whatever, there is no difference in the quantity. The quantity will be only dependent on what quantity you can use. That's all.
Thank you.
Yadav, if some tablets are found missing, what are the worst troubles the doctor in charge has to face? Now, this is a real case scenario. At one time, we studied more than in Calicut 1,700 patients. Everybody was part of the study over a 2-year study period. We were just looking to see if there was any unauthorized use. And we found one day 100 tablets were missing. So what we did was, we immediately made a paper record of this in a file, said the 100 tablets are missing. The person who was in charge of the pharmacy at that time has to stay off that duty till the matter is resolved, hand it over to somebody else. And then the reasons were searched. Could it be an error in calculation in the register? What else could have happened? And they actually found that two envelopes had slipped down behind the shelf and were lying in a small gap between the cupboard door, wall and the drawer. It was found. But suppose we hadn't found it. This is tricky. What we will have to do is to report it to the drugs controller with an explanation saying that these are the things that we did and there has been a discrepancy. We instituted a search and we find that somehow a genuine error in the calculation must have happened. What Amrita did once when we had such a situation was to ring up all the patients who were given morphine the previous day. And she found that somebody had been given more than what was due to them. So you try to do it, but Yadav, if you feel it is suspicious, we should be reporting it to the police. You and I may get into trouble if we conceal something like that. But then this is not only about this. You have been using injectable morphine. This has been going on for so many years. Oral morphine is less of a problem than injectable morphine. Ashok, if this patient in Andamans needs a refill, I'm sorry. Unfortunately, even if he doesn't come, a family member will have to come. Because you cannot dispense it. Oh, wait a minute. Yeah, unfortunately, this man is in Andamans. He has left the place. We could courier it if you have a doctor who can verify. And if that doctor is from, like we did, you know the doctor, you appoint him an honorary physician or appoint her an honorary physician, and you take the responsibility. Otherwise, it becomes tricky.
Okay, thank you.
My heart goes out to that 9-year-old child in Andamans. Let's hope that he or she doesn't get pain.
Yeah.
So Sunil obviously couldn't find a slide. So Sunil and Amrita, we should have one just to show the example. Because doctors and nurses have a reputation to be poor at mathematics. Now, anything that you do in palliative care is almost totally safe. With anything that you do, it's next to impossible to kill a patient, except when you do calculations and you do equipment like the syringe driver. You make a mistake and add an extra zero, and the patient gets 10 times as much. So this is important. So suppose, as I said earlier, the patient was on 10 milligrams of morphine 4 hourly. And you find that the patient was not taking any rescue dose. So the daily requirement was 60 milligrams. Whose question was that? Was it Dimple?
Yes, sir.
So Dimple, 60 milligrams oral. What would be roughly the equivalent dose of an injection? Anybody can answer the question. Oral to injectable conversion.
IV 1/3, sir.
Yeah, 1/3 is a good rule. 1/3 may not be enough. You may have to increase, but you start with 1/3. So 60 milligrams was the oral dose daily, and 20 milligrams a day would be the injectable dose. 20 milligrams, if you, like us, have 15 milligram per ml apule, 20 milligrams may be a little odd to take. Maybe you will compromise at taking 21 milligrams or whatever. Just take that, dilute it into 10 ml. The daily requirement, if it is every day, as Raju said, the daily dose is diluted to 10 ml, and the family member is asked give 1 ml every hour. Or like we do, sometimes if we want to give it for 2 days, we may just dilute it to 10 ml and wait, 6 1 and ask the patient to give half an ml every 4 hours. So Sunil, towards the end of my statement, I found my maths. Did I make a mistake?
No, I think.
I think I confused you also successfully.
Sir,
Amrita?
what I usually do is 1 ampule is 15 milligrams.
Yeah.
So I take 1 ml plus 9 ml of normal saline, which is 15 milligrams in 10 ml. So, and divide it by the number of doses you want to give. Whether if it's 4 hourly, then you make it into divide by 6. So 10 ml divided by 6, which is almost about 1.5. And we ask them to give it 4 hourly.
1.5 ml.
Yeah.
Okay.
4 hours.
Okay, that's fine. But our own practice over the years evolved that the least confusion, people are not used to giving injections, family member. It's a big responsibility. Somebody says, I can't do it. But just one step. Yeah, that means our calculation is easier. The patient has to be taught how to give 1.5 ml every hour. What? Yeah,
Sir,
yeah.
Sir, particularly when there isn't much of subcutaneous chamber, 1.5 ml subcutaneous injection can be very painful. Generally, it will be either 1 ml or less for each dose.
Yeah. Thank you, Raju. The smaller the quantity, the less the pain for the patient, Dr. Biju. That's the only concern.
Yes, but if it's suppose it's with a syringe pump, then it's a continuous infusion. So
Syringe pump is another matter altogether. Syringe driver, friends, if you have particularly an inpatient unit, and it's not okay. How much does it cost now? It used to cost about 35,000 rupees.
Now, sir, we get everything on rent, sir. We can get it on rent. So
okay, I see. Okay. Now the most important thing about syringe driver is be sure of the calculation. If you feel you are not good at maths, get somebody else to help you.
So what we usually do is we go and set it up for the patient, and then that goes on.
Yeah. Dr. Biju is obviously very confident about his mathematics. I'm only talking about people like me. And this is my worry. This has happened globally. In many places, this has happened. This is one place where one error means 10 times the dose being delivered. And this is the only process in palliative care when you can make a mistake and kill a patient. I wish I could be as confident as Dr. Biju. Oh my God.
So we used to do that in pediatrics. So we used to double check all the time. Right.
Yes. 7:25. Almost all questions exhausted now. People are also exhausted.
Not when you are talking, sir.
Oh, my God, what a compliment for me to take to bed with me and nurse it at night. Thank you, one thing that now that we have 5 minutes more, 4 minutes more, and if I leave early, Supriyas will get very annoyed with me. So let me use that time. Just we said contact us, we will help. This happened in another state, 3 years, just before the COVID days. Yes. So the new rules were explained. The drugs controller was involved. They agreed to it. They agreed to everything. But then when the application went, a drug inspector came And he asked for several things. He asked for a floor plan of the institution. Bapre, floor plan. If your institution is 35 years old, not even historian can find the floor plan of the building now. What and how does it help? Good heavens. They asked for approval by the registration with the National Accreditation Board. So many things. So the hospital said, the institution said, we would rather go back to the old system. Why you do all this? We persuaded them to stick to it. So with their permission, I wrote a letter to the drugs controller of the state by registered letter. Any communication has to be registered post, and you should have a separate file for this. Keep all the records. So I sent him a letter saying that these things have been asked for. These are against the law of the land. There is no stipulation in the rules that NABH accreditation is necessary. There is no stipulation in the rules that the floor plan has to be submitted. They have the only requirements are that they should have a safe place to keep the morphine and a doctor with training. Both have been satisfied. Please intervene on the behalf of the people in pain. Now, fortunately, the drug controller intervened. It was only somebody who did not understand or somebody who wanted a bribe doing all that. They intervened and it was done. But not every state will be that easy. There are some states that are very resistant. But if we don't act now and knock on their doors, never get angry with them, never quarrel, but be insistent, demand for what is right for our patients. And that's our collective responsibility. Oh, one more question has come and we have just 1 minute. Patient CA lung brain meds, 36 years, multiple anti-epileptics, and a sedation with oral morphine, fentanyl patches, change patch every 24 hours because of increased pain. Please advise whether to take oral morphine. Listen, if money is not a problem into, the dose of fentanyl is obviously not enough. You put in 2 patches. If the patient's requirement of morphine was worked out earlier, then this can be switched on. The patient requires more. When the blood level is at its top, the patient has pain relief. It drops a little bit, the pain comes on. What does that mean? The dose administered is inadequate. You have to increase it. So the patient next day has to have 2 patches, and that should be enough. Okay, ladies and gentlemen, thank you for the patient listening and interaction.
So okay, I just wanted to know: is the you said that different registers are maintained for each drug being given? Is there any role of electronic medical records? Then is that a better option?
By the way, the formal session is over. Time is up. Anybody is free to leave. Don't want to keep you waiting beyond time. Dimple, it's not the law. No, law says nothing about, it says about documentation. So that should be okay, acceptable. But I would still keep a paper record. I don't know if it is just because I am an old person, or I'm wondering, okay, the drug inspector comes. There is a power outage. You cannot open the file. Something goes wrong. If you are quite sure that you will have a backup for your computer every day and will be able to access any document the next day, even if your computer fails, then that should be fine, I think. But I'm not so confident that we'll be able to ensure that kind of backup of your computer every day. And that can be a problem. So, excellent. We also have the data entered on the computer, but we still continue to have hard copy. We may change it in future. Amrita, I don't know what Amrita will do in 2024, but right now we are doing this.
Sir, if it's a hospital, then the EMR is backed up on the cloud, sir. So
yes. So yes, to the best of my knowledge, there is nothing against this, but for practical reasons, just get a concurrence from the drugs controller or get him to agree to this. That will be safer for us. Okay.
Thank you, sir. Correct, sir.
Sorry?
Hackers will, at least hackers will not attack the registers, I believe.
No,
That is
you take that on and argue it out. When you talk about the cloud and everything, I've lost myself in a cloud. Thank you, everybody. എവിടെ കൊണ്ടുപോകുന്നു എന്നൊരു ചോദ്യം മ്യൂട്ട് ചെയ്യാതെ ചോദിച്ചത് എല്ലാരോടുമായിട്ട് അവിടെ കിടക്കും. ശരി. ഓക്കെ ഫ്രണ്ട്സ്, ബൈ ബൈ, ഗുഡ് നൈറ്റ്.
Thank you, sir.
Thank you, sir. Thank you for joining in. And without Sunil, sir, I think is muted. So thank you.
Please go on, sir.
Thank you everyone for joining in, and I believe that as usual it was a fabulous session by the legend himself, Dr. Rajagopal. Thank you for joining in, and just reminding that the next session is going to be our last session for this batch. This is Sri Priya along with Dr. Sunil Kumar signing off from the Tips Eco Hub. Till the time we see again.
1 minute.
Sir.
So maybe everybody would be asked to tell something about your feedback in the last session. So I would request you to just be prepared so that we can actually find out our faults and we can improve our course for the next batch. So please think about it, how to improve our course. Thank you.
Definitely, we'll be looking forward to your valuable and kind words during that session. So till we meet next, take care. Bye-bye.